Hello, everyone. I'm continuing the review session, and we're going to do health promotion and maintenance. Under that, it's developmental stages and transition, and the topic is older adults, 65 years and older. Identify expected changes in development. And so we see that there are a lot of changes that older people do have in terms of physical development. In terms of their skin, there is decreased skin turgor, subcutaneous fat, and connective tissue, which leads to wrinkles and dry, transparent skin. So it's pretty much their skin is thin and fragile and can easily tear. There's loss of subcutaneous fat too, which is why it's difficult for them during cold temperatures. Actually, there is a big list given in page 121, chapter 25. So you can go over that because I am not sure what type of question it is, but it says it's identifying expected changes in development. So it could be any kind of development. And so physically, as I said, you do see changes in integumentary system, in cardiovascular, in neurosensory, because they react slower than the younger person, GI, neuromuscular, genitourinary, endocrine. So in all of these systems, they do have some changes. So I do not know particularly which system they are being they are questioning you on. So please go over that. I am sure it must be more towards physical development. In terms of cognitive, it's just that sometimes because of infections or other disease conditions, they can have delirium, depression, or dementia. So that could happen in older adults. And in terms of psychosocial development, according to Erickson's, they are under integrity versus despair. That's their developmental stage. And so this is the time where they have to adjust to lifestyle changes and adapt to changes in family structure and adapt to changes in the living environment, deal with losses and things like that. So it's basically, if they are successful in dealing with all of this, if not, they're going to be in despair. So that's about briefly about cognitive and psychosocial, but I want you to review a little bit more about the physical development changes that the older adults have, which is again in page 121. Going on to the next part, which is health promotion, disease prevention, about hygiene and urinary elimination. So hygiene, under hygiene, they're asking a question about bathing a client who has dementia. And so, demented patients or patients with dementia, they have loss of memory. And so that leads to confusion. And so sometimes that can even lead to mild agitation. So yes, if they really need to have a bath, please do give them a bath. So because their hygienic needs cannot be neglected, but again, see whether there is a need for that. And also, calm communication is essential for a patient with dementia because they can get agitated soon. And so reorientation and calm communication is very essential. Don't leave them alone, but again, assess the situation and then appropriately care for them. So that's about caring for a client who has dementia. Going on to effects of aging on urinary infections. We did see that they do have changes, they undergo changes. We didn't particularly go to the genitourinary system, but if you look at that system, you will see that they do have changes, and that is why these older adults, they do have increase in nocturia, and some of them can get incontinent because of that. They glomerular filtration rate is a little lower, fewer nephrons. They do have loss of muscle tone in the bladder, which can lead to frequent emptying of the bladder. And also inefficient emptying of the bladder will lead to residual urine, and which can increase the risk of UTI. So we want to remember that they can easily get a UTI, and that can again lead to other issues. And one of the manifestation is confusion in older adults when they have UTIs. So you want to remember that. So these are the effects of aging on urinary infection. They are at a higher risk because of the residual urine relating to the bladder changes that they have at that older age. Going on to the techniques of physical assessment, the theme is appropriate technique for abdominal assessment. So that's given in 155, and it talks about how you need to assess the abdomen. So definitely you want to use the techniques of inspection, auscultation, percussion, and palpation. So here you see that the order of assessment is different. Auscultate just immediately after inspection and before percussion and palpation, because you don't want the vowel sounds to be altered. Remember, there are 4 quadrants, and you want to draw an imaginary line through the umbilicus to divide the abdomen into 4 quadrants, from the xiphoid process to the symphysis pubis. So there's a right upper quadrant, left upper quadrant, right lower quadrant, and a left lower quadrant. And when you document, you want to particularly say what you inspected, or what you auscultated, what you palpated and percussed in each of these quadrants, especially if they're abnormal. You want to particularly specify which quadrant it was. So I think the question primarily maybe asked about auscultating before palpation. All right. Now we go on to the psychosocial integrity section. Under that, we have coping mechanisms, and we're asking about preschoolers and how they analyze response to stressors. You need to remember that preschooler, that particular stage falls between 3 to 6 years. And in terms of their psychosocial development, they are under that initiative versus guilt stage, and they do take on many new experiences. And if they're not able to accomplish a task, then they can feel guilty. So this is also a stage where they kind of have self-concept development, and they feel good about mastering skills such as dressing and feeding that allow independence. Now, during stress, insecurity, or illness, they tend to regress to previous immature behavior or develop habits such as nose picking, bedwetting, or thumb sucking. So I think probably this is what they are trying to ask you about, how they respond to stress and stressors. And so you want to understand that they can regress to their previous immature behaviors or habits, such as nose picking, bedwetting, or thumb sucking. Sorry. And there are a few other growth and development information in page 101 if you want to go over the development of preschoolers. But in particular to stress, this is something that I think is going to be asked, and I just discussed it now. Going on to grief, loss, and palliative care. The question here is on identifying anticipatory grief. You remember that in the class we talked about the different types of grief, and here they're asking about anticipatory grief. And so anticipatory loss itself is experienced before the loss happens, and a grief is basically anticipatory grief is, again, this grief also implies the letting go of an object or person before the loss, as in a terminal illness. So the patient, when they have a terminal illness, you know the person is not going to live very long and you're going to lose them soon. So the individuals actually have the opportunity to start the grieving process before the actual loss. So in a way, it gives them a little more time to adjust to the loss that is coming up. So that's about anticipatory grief. Going on to the next one. Self-concept and sexuality, providing client support following mastectomy. So definitely mastectomy can affect their body image and their self-concept and self-esteem. And so how can we support them following a mastectomy? So it's important that we establish a therapeutic relationship with the client. A caring and non-judgmental manner puts the client at ease and fosters meaningful communication. Make sure that you ensure privacy and confidentiality. Let the clients know that it's safe to discuss those sensitive issues. So identify individuals who can be at risk for body image disturbance. So I think there is a question in the next page in 187 about who are at risk for body image disturbances. It talks about a person with mastectomy, a person with amputation, a person who has weakness after a stroke. So all of these people are at risk for body image. A person going through a cardiac catheterization procedure will not be at risk for body image disturbance, but especially when they are losing part of their organ or body or its function, then definitely the body image issue comes into play. Acknowledge their anger, depression, denial as feelings to be expected when adjusting to body changes, and encourage them to participate in the plan of care so that they can suggest what they want and how they want their care to be and how people around can help them. Arrange for a visitor from a volunteer who has experienced a similar body image change. Listening from somebody who has already gone through that same difficulty and being successful would motivate a person with body image issues. Another question is there again. It says the client is saying, my body is so different now, and how should a nurse respond? So it's not that you're putting away their statement or not trying to be defensive or play down. No, I think the appropriate response here is, I'm interested in finding out more about how your body feels to you. So it's always therapeutic communication is open-ended and trying to help the clients ventilate their feelings and open up to you. And being a good listener will definitely help them. Going on to therapeutic communication, therapeutic response to an adolescent client. So a little bit about therapeutic communication, and then the principles. I think you need to remember those principles of communication as to how you need to be honest, true, show empathy, and show a non-judgmental attitude, a caring attitude, have enough time to listen, and be attentively listening. Active listening is very essential. So this therapeutic communication will help to build and maintain that relationship with the client. If it is an adolescent, then all the more, because sometimes they feel that they are not heard. And so using the right techniques will help in maintaining a trusting relationship with the adolescent. Few other therapeutic techniques are, I already said about active listening and asking open-ended questions, clarifying if you're not able to really understand what is being said, focusing, summarizing, showing acceptance and recognition, offering self, presenting reality, silence. These are all some techniques that are helpful when you're maintaining a therapeutic communication. And particularly in terms of dealing with an adolescent, you need to understand that adolescents communicate one way with the peer group and another way with adults. So use open-ended questions to communicate and discuss sensitive issues. They do have a lot of sensitive issues, and so you want to remember that when you're communicating with them. Again, if you want to look at the development of adolescents, it is in 109. Going to assistive devices. So we're going to the next section, which is basic care and comfort. So assistive devices. Under assistive devices, it talks about appropriate use of crutches. I think you do have a section somewhere about use of crutches. So you definitely want to remember about the positioning of the crutches, about how your elbows need to be flexed, like 30 degrees, and there needs to be a gap of 6 inches on the front and side. Just trying to see where it talks about crutches. So in ATI questions are mostly related to your skills. So please review all your skills lab, skills that you learned in skills lab and assignments that you did, because all of them are, meaning basically how you care for your patients, and ATI is concentrating on evaluating your knowledge on how you will get care and the skills that you will use with the patients. Trying to see, I can't really probably I'm not at the right page, but you definitely did an assignment on crutches and so use of crutches. But these are some things that you want to remember. You don't want to put pressure on the axilla because of the axillary nerve compression. Remember that it needs to be at the greater trochanteric level, and the elbows need to be flexed at a 30 degrees, and you want to have a gap. And always remember the crutches need to go first, and then the legs will follow. All right, so that's about it. And then going on to urinary elimination, preventing skin breakdown. So, anytime they are incontinent, when there's moisture in the skin, there is a high risk of skin breakdown. And so you definitely want to keep the skin clean and dry, assess for signs of breakdown, apply protective barrier creams, implement a bladder retraining program so that they go to the toilet on a specified time, and they can stay dry and not be incontinent. So it's very important to prevent chronic exposure to urine, and also definitely improves the patient's dignity and also prevent a lot of complications from the moisture being around the skin, on the skin. The next one is about preventing thrombus formation, mobility, about mobility and immobility. There are a lot of complications of immobility, and so you definitely want to prevent those complications. And so one of the complications is thrombus formation, like they could be called as thrombophlebitis or DVT. And so it's important that you use different ways to enhance venous return and prevent thrombus formation. So use of elastic stockings, SCDs will definitely improve circulation and promote venous return. Positioning techniques also will reduce compression of the leg veins. Range of motion exercises, and also mobilizing the client as soon as possible when he or she is able to will definitely improve circulation. So you want to remember how to apply these SCDs, anti-embolic stockings. Remember, when you're putting the stockings, you want to first put the stockings when they are in bed before they get out. And also, you need to check the skin, especially for any issues. And also, it needs to be, if they are sometimes they're wearing it for 24 hours, then they usually go onto the bed and then remove the stockings. Once they have been diagnosed with a DVT, then of course you don't want to be doing any massages or connecting to them to the SCD machine, but you want to notify the provider immediately and position the patient in bed and give them some bed rest until treatment begins, and with the leg elevated. So that is when a thrombus is already formed, but before that you want to prevent thrombus formation by promoting venous return and improving the circulation in the extremities. Next one is pressure ulcers, wounds, and wound management. How do you assess a skin condition? So, it's very important to do a periodic assessment. You'll remember the scale that is being used in the healthcare settings, the Braden scale, which tells you if a person is at risk for pressure ulcers. So definitely use of that will help identify if a person is at risk for developing pressure ulcers. But otherwise, also, you want to look at the skin and you want to see if there are any wounds or any pressure ulcer, even if it is just stage 1, which is non-blanchable erythema, or stage 2, which is partial thickness involving the epidermis and dermis, and stage 3, which is full thickness skin loss, where there's damage to the subcutaneous tissue, and stage 4, where there can be damage to the muscle, bone, or other structures. And of course, there's unstageable pressure ulcers too. So when you're inspecting the skin, you want to look for any types of pressure injuries, pressure ulcers, and look for any wounds. And when you're looking at the wounds, you want to look at the different colors that are in the wound to see how it is healing. You also want to see if there's any drainage in those wounds. We talked about different types of drainages: serous sanguinous, and purulent drainage. Look at all of those again to make sure that you're inspecting and assessing the skin and the wounds, and also preventing anything new from occurring. And maintaining skin hygiene is very important. Clean the skin with a mild cleansing agent and pat it dry if they are especially incontinent. Bathe with tepid water, not hot. Don't scrub the skin. Don't use too much powder or cornstarch. Active and passive exercises for clients who are immobile. And do not massage bony prominences. Use barrier creams as needed. So these are all some things that you will definitely do to make sure that the skin integrity is maintained, and maintain skin hygiene, avoid skin trauma, and provide supportive devices to prevent any breakdown. Going on to non-pharmacological comfort interventions, complementary and alternative therapies. They particularly asked about ginkgo biloba. So that, as you know, is part of a complementary and alternative therapy. And something that you want to remember about that is if they're hypersensitive to that particular substance, ginkgo biloba, you don't want to use it for patients. So it's contraindicated for those who who have hypersensitivity to ginkgo preparations. Of course, one of the adverse effects is bleeding, but here they're particularly asking about contraindications, and that's if they do have any hypersensitivity towards any of those kind of preparations, you want to stay away from it. The next one is nutrition and oral hydration. So that's about fluid imbalances, hyperosmolar imbalance. And I know we have to talk a little bit about fluid and electrolyte imbalance, and I'll try to do it next class. But if you're going to be asked, I didn't see anything about electrolyte imbalance, but I do see about fluid imbalance. So about fluid imbalance, you want to understand there are two types of imbalances. One is when there's a fluid volume deficit, and the other one is when there's a fluid volume excess. And so there are different compartments in our body, and our fluid is distributed in those compartments, which is within the cells, which is intracellular fluid, outside the cells, extracellular fluid, and the extracellular fluid is in your blood vessels, in the interstitial spaces, in different other cavities. So that's all comprised of the extracellular fluid. So these are two main, intracellular, extracellular fluid. So fluid can move between compartments, but again, especially when there is loss of water and electrolytes from the extracellular fluid, particularly in your blood vessels, then it's called as isotonic fluid volume deficit. Here, particularly the question that they're asking here, I think, is on hyperosmolar imbalances. And so that pretty much refers to dehydration, where there's loss of water from the body without the loss of electrolytes. So you're losing a lot of fluids, and so therefore your blood is going to be concentrated. So there's an increase of hematocrit, and electrolytes can be more, and the urine specific gravity also is going to be concentrated. So that's hyperosmolar imbalance. And you want to remember that dehydration, fluid volume deficits can lead to shock, hypovolemic shock, because the volume is low, and it can lead to shock. You know the signs and symptoms of dehydration. I'm not sure if you've learned it in another class, but when the volume goes low, then there's going to be, your heart tries to compensate, so you'll have tachycardia. It's going to be weak, but it's going to be weak, thready pulse, tachycardia, hypotension. Your blood pressure is going to be low. Remember, the volume is low, so hypotension, orthostatic hypotension, decreased central venous pressure, tachypnea, hypoxia. So these are all some of the changes in vital signs. Of course, the temperature can go down to hypothermia. In terms of musculoskeletal changes, the patient is not, if there's not enough blood circulating, then less blood is going to the brain as well. So they'll have dizziness, syncope, confusion, weakness, and fatigue. And of course, GI, the patient is going to be thirsty, dry mucous membranes, nausea, vomiting, anorexia, weight loss. Renal, they're not going to be urinating much, so oliguria. And of course, other findings would be cool, clammy skin, and diminished capillary refill, sunken eyeballs, flattened neck veins, absence of tears, decreased skin turgor, and diaphoresis. So these are all the signs and symptoms. I'm just adding on to them. I know it doesn't specify what the question is on, just as hyperosmolar imbalance. Of course, it's understanding what that is, and then I just added on a little bit more about what you will find. As I said, the hematocrit may be increased when you check the labs, the sodium may be increased, the increased concentration of urine, specific gravity will be increased, and serum osmolarity will also be increased. And of course, the management goes on to say that you need to replace fluids immediately. So isotonic solutions are given to replace the fluid. If the patient is able to drink it orally, of course you can, but depending on the stage that they are in, they may need an IV infusion. So that's about it. The next one is calculating intake, nutrition and oral hydration. And about that, let's see what is given. I think, it just about intake output. It's just telling the importance of monitoring intake output for clients who have fluid or electrolyte imbalance, or also who have certain disease conditions where really need to monitor what they're taking in and how much they're putting out. So record the intake output, weigh clients each day at the same time after voiding and while wearing the same type of clothes. So, weight is a good indicator of the fluid status in your body. If you're using bed scales, use the same amount of linen each day and reset the scale to 0 if possible. So that's about intake output, and you have learned about calculating the intake output in your calculations too. So I don't know if it is a calculation question, but remember that you need to record and monitor intake output accurately. Pure diet. Pure diet is just a diet. It's one type of therapeutic diet, and it's the consistency is different. Clear and full liquids are part of the puree diet, and plus they puree the meat, the fruits, and pureed meats, fruits, and scrambled eggs are all part of the puree diet. So these are given to patients who have difficulty in swallowing before they transition to a regular diet. They sometimes go through these types of diets, which are different in its consistency to prevent aspiration and other complications. Enteral and NG tube feeds, unexpected finding is the next topic. So I think that's discussed in chapter 54. It talks about so what are unexpected findings? I'm sure they're referring to complications. So you want to, if it's an NG tube, you want to see if there is any blockage in the NG tube, and if there's permission to irrigate the tube, then you can irrigate the tube to make sure that it is functioning well. Sometimes the NG tube can be connected to a dependent drainage, and so there you want to definitely look at the color of the drainage and report, especially if it is there's blood, coffee ground, blood streak, dark or fresh red, fresh blood. Definitely, if you see any of those, you need to report immediately. Also, look at the skin and the nares and see if any lubricants are needed, and switch the tube to the other nair if needed. In terms of enteral feed, you need to check if the residual exceeds 250 ml for each of 2 consecutive assessments. You may have to withhold the feeding, notify the provider, recheck residual in 1 hour. Always when you're feeding, put the patient in semi-Fowler's position or a great greater. If they have diarrhea, it could be that the rate is too fast, so notify the provider. The rate may need to be slowed down and talk to the dietitian, ask for a consult. There can be other problems like aspiration, so you definitely need to withhold the feeding, suction if the patient, if you know that the patient is aspirating, and notify the provider, check for congestion. They may need to do an x-ray. Nausea, vomiting, you definitely want to, again, make sure that the patient doesn't aspirate, and so keep the head of the bed at least 30. Make sure the formula is at room temperature, slow the rate of installation, turn the client to the side, and again, notify and see if they have a lot of residual too. So that's about watching out when you're giving enteral tube feeds or when the patient is on NG tube dependent drainage. The next one is on personal hygiene, grief, loss, and palliative care, providing post-mortem care. And I know you did an assignment on that. And so post-mortem, as you know, may be done for different reasons. And so, I'm talking about autopsy. I'm sorry. So the care of the body is important, and after death, and so provide care with respect and compassion while attending to the desires of the client and family, according to their religious, cultural, and social practices. So make sure that the body is prepared for viewing. You want to maintain privacy, remove all tubes, unless organs are to be donated. Remove all personal belongings to be given to the family. Make sure that the body is cleansed and align the body spine with the pillow under the head, arms with palms of hand down, outside the sheet and blanket, dentures in place and eyes closed. Apply fresh linens with absorbent pads on bed and a gown. Brush or comb the client's hair. Replace any hair pieces. Remove excess supplies, equipment, and soiled linens from the room. Dim the lights and minimize noise to provide a calm environment. And ask the family whether they would like to visit with the body, honoring any decision. So after the viewing is done, apply the tags and complete documentation and transport the body. Remain aware of visitor and staff sensibilities. So we definitely need to follow the laws regarding organ or tissue donation, obtaining permission for autopsy, etc. So all that needs to be done as well. So that's about postmortem care. I know it's given in page 198. You can definitely look at that. And the last one under this section, basic care and comfort, is interventions to promote sleep, rest and sleep. I think you're going to talk about it tomorrow in class. So that will be fresh in your minds. But remember that some of the interventions that promote sleep are establishing and following a bedtime routine as to how the patient was used to before coming to the hospital. Limit waking clients during the night. If the client requests, you can try to space out going and disturbing the clients as much as possible. Promote a quiet hospital environment. If they need a back rub prior to sleep, you can help with that. Some of them need CPAP machine, continuous positive airway pressure machine or device when they have sleep apnea. So you can consider that as well. Consult the provider about trying sleep promoting over-the-counter products like melatonin. So sometimes that helps. And sometimes, if not, medications can also be given. There are different drugs that the doctors can prescribe. If it's really needed, you can notify the doctor. And teach the clients as they go home too that they need to establish a bedtime routine and regular sleep pattern. Exercise regularly at least 2 hours before bedtime. Limit alcohol, caffeine, nicotine at least 4 hours before bedtime. And limit fluids 2 to 4 hours before bedtime. And engage in muscle relaxation if they are stressed. And make sure they are comfortable as they sleep. So that's about interventions to promote sleep. If the patient is, again, used to certain routines, try as far as possible to accommodate that. So that's about it for now. There are, I think, three other small subsections. One is pharmacological and parenteral therapies. The other one is reduction of risk potential. And the third one is physiological adaptation. So I'll try to do it on Wednesday, but if any of you feel differently, let me know. Then I can try to do a similar session. Thank you, and I hope you all will prepare well and do well in the ATI final exam. Thanks.